So, hello friends. I've been giving a overview on this very interesting topic, AI in sepsis. So, I was asked to deliberate on this in AI summit that happened in Bangalore in association with ISCCM. So, I bring greetings from these hospitals I represent, Manipal Hospital Yeshwantpur and Manipal Hospital Yelahanka. So let's now just look into the established facts on sepsis. So sepsis is a deadly condition. Every 3 seconds, one person dies. And look at the global burden of sepsis death. It has far exceeded cerebrovascular and stroke deaths at 48.9 million per year, which is close to 5 crores. And per year, there are 11 million deaths that tends to happen per year. And there are, out of this, 4 million deaths are due to antimicrobial resistance. And 85% of the global burden of the sepsis come from the lower and middle income countries like Africa, Asia, and Latin America, which we represent. So this is quite staggering and alarming. And the hospital mortality, the leading cause of hospital mortality is also due to sepsis in these countries. So these are some of the facts just to have a context setting as to why having AI sort of an algorithms incorporated goes a long way in averting these deaths or minimizing the deaths. So what are the reasons for the sort of a bad outcomes in sepsis? Some of the reasons is the outcome is influenced or determined by delay in the diagnostics. And there is a whole lot of a clinical heterogeneity in sepsis because we have clearly understood, friends, that there are different phenotypes of sepsis like hyperinflammatory, hypoinflammatory, or immune paralysis, so on and so forth. And each of these phenotypes behave differently, and it's the sort of, and sepsis is a dynamic process, and the host factors and the evolving response to the sepsis from the host also determines their outcome. So these are some of the broad sort of a tenets as to which influence the outcome in the sepsis. So what does AI do? So AI helps in integrating all the data and gets an insight and have and possibly helps us in timely creating or having a timely action plan. And machine learning algorithms. So when we say AI, there are three important components which help in integrating this data. So machine learning tools, along with predictive analytics and real-time capturing of the data that is emanating from the monitored variables or from the investigations or from the clinical findings is what are integrated to establish the plan. And this has created a paradigm shift in the ability to detect the sepsis early, which we'll talk, diagnose sepsis early, and because there is a real-time synchronous flow of data, there is dynamic sort of a management plan that is made for the sepsis. So this is something that AI is revolutionizing. So it takes data and puts it into machine learning algorithms, and there is some sort of a predictive analytics that happen, and it integrates the real-time data and helps in optimizing the management. So now the question is, in sepsis conundrum, why is it that AI matters? Because we understand it's in sepsis, there's no single biomarker which influences the outcome in sepsis, and there's no single definition. Although we say it's a life-threatening organ dysfunction due to dysregulated host response to the infection, but because of the phenotypes, this definition also can be variable. And the clinical science of sepsis is very non-specific. And when there is an infection, it's very hard to determine as to which are the group of patients which rapidly progress to the shock, and it is fairly unpredictable. We don't have certain predictors to indicate who are the ones who go into shock situation. And the challenge is the lack of data and lack of timely action. So these are some of the challenges that one faces while addressing the case of sepsis. So now what are the tools we have? The tools we have in ability to predict our SIRS, SOFA, and QSOFA, which are all taken from the retrospective data, and these are validated, and they fail to capture temporal dynamics and fail to capture the individual phenotypes or individual variability, which are not factored into these conventional tools that we tend to use to help us prognosticate the sepsis. So these are some of the key sort of challenges that we face. So when you look into the current ICU, friends, I would say intensivists or the intensive care patients who we deal with are the patients with largest amount of data. So we are dealing with a data rich environment, friends. And the modern ICU, the science suggests there is 1,000 data points per hour which gets emanated from a busy patient who's on ventilator, vasopressors, so on and so forth. Per hour, we are meant to integrate 1,000 data points, and you can imagine how ridiculously difficult it is for us to synthesize and make semblance of this. And these 1,000 data points come from these monitors. If you look into the monitor itself, there are so many variables, and you take minute to minute variables, you can imagine the type of data. And the data comes from the lab. So when you integrate all these, it is up to 1,000 data points. Before, I used to make a claim that we deal with 250 variables at any point of time, but now it looks like we have 1,000 data points and all the data that comes from all the instruments and gadgets patient is connected to. So the approximate is around 1,000 data bits per hour. And humanly, it's not possible for us to integrate this data pane. So the AI helps us in integrating all this data very fast and in a very continuous way. And human mind can get enormously sort of fatigued in trying to integrate this, but there is no fatigue component with AI. And AI helps in augmenting the reasoning and looking into clarity in the chaos. I always tell intensive care is all about having clarity in chaos. So that's what AI does. AI in the data chaos, it helps to ascertain or establish clarity and helps us in making good clinical decisions. So early detections and prediction models, as I said, AI, there are already algorithms in place which are able to predict sepsis early. As I said, AI is integrating of, it's a simulation of human intelligence with predictive analytics, helps in decision making. And machine learning tools is similar to AI, where it collates large data set, like 1,000 data points per hour, it integrates and looks into the common pattern, recurring patterns that tends to recur and make semblance of it. So what are the different models that are currently available which are able to predict sepsis? So there is this model called ACE, AI Sepsis Expert, which tends to integrate the heart rate, map, and all the variables from the electronic medical records, and it is shown to predict sepsis 4 hours prior to the onset of clinical sepsis with area under curve of 0.85. Then this is a Swedish sort of an algorithm which is long short-term memory, where they have looked at 59,000 patients from the MIMIC database, which is Medical Information Mart in Intensive Care 3 database, where they collected all the clinical records with vital signs and the lab data and ascertained the clinical outcome. They compared area under curve versus Cox proportional hazard, and they found the AUC of long short-term memory was much better with 20 hours, with the ability to predict sepsis 20 hours prior. And this was a study from UK where they fed in all the cytokine variables, all the different cytokine variables put into the deep neural network, and they found the outcome prediction happened with an accuracy of 94.55% and very high sensitivity, friends. So these are all the algorithms that have shown in a very consistent way its ability to predict and prognosticate. This is a Taiwanese study where they integrated sepsis 3 definition with SOFA scores, and they put 106 elements along with organ dysfunctions in patients with sepsis. And they found that the timely diagnosis of sepsis happened with an accuracy of more than 80%. And then there is this SERA score, which is sepsis early risk assessment. So it warned intensivists 2 hours in advance. And what did they take? They took again all the medical records, the lab data, and they compared with the clinical and QSOFA. So this came from the Singapore, and they showed that the SERA score outscored the clinical examination or the clinical acumen with QSOFA and SIRS, and AUC ROC was 0.94. So you could see that all the AI algorithms which have been studied and published show sort of a superior ability to predict sepsis and predict the outcomes in these patients. And this is just a template to see how the data capturing is done and data integration is done, as you see. And so this is the sort of algorithms that are fed into AI systems to help us prognosticate. So now it's about precision management, whether AI is helpful to manage patients in a very precise way in sepsis. So when we look at the fluid and vasopressor optimization, there are AI algorithms. So these are some of the algorithms, MIT, AI Clinician, or Nature Med 2008, where they looked at 40,000 ICU episodes and to try and see if these algorithms helps to optimize titrating the fluids and titrating, because the whole science of intensive care is all about fluid responsiveness and how much fluids to give. So using this AI algorithm, titrating the fluids and vasopressors, it really mirrored the expert level decision making. So it was very similar to an expert, how he would decide with regards to how much fluid and how much vasopressors. And these algorithms showed improved outcome when they retrospectively validated with a clinical expert. So this is what is the science evolving. So it helps us in optimizing fluid and vasopressor management. What about stewardship? Because AI has a very good ability to integrate antimicrobial resistance with the hospital-based antimicrogram and the host factor. So it tends to integrate the evolving AMR that is prevailing in the community along with the hospital-based antimicrogram and the host sort of a internal milieu, and helps to determine the choice of empiric antibiotics, which is the right antibiotic with the highest probability of coverage for the possible bugs that patient would have. So it really helps even in good antimicrobial. And we saw the in sepsis globally, 4 million deaths out of 11 million happened due to antimicrobial resistance, and AI helps in that. And how about hemodynamic and organ specific predictions? So AI is helpful in forecast. I think there are algorithms incorporated into the monitors in the operation theater, and the studies have been published where AI has been helpful in predicting the hypertensive episodes, and it helps to forecast impending hypertension, impending AKI. And this prediction happens 6 hours prior to the onset of hypertension, and proactive interventions could be put in place. So these are really incredible as to where AI is making a difference. And in ventilated patients, AI has been shown to help optimize. There is a separate video I have done where I've spoken about AI in ARDS or respiration. It helps to optimize PEEP, and there's so much science that or we need to put in our mind to optimize PEEP and weaning readiness, which is tailored to the patient's physiology. So this is where we are heading, friends. So now, having said all the beautiful things about AI, but there are challenges. What are the real world sort of a challenges and barriers? So one thing is the quality of data that is fed. So you put a rubbish data, so obviously the predictions also become rubbish. So garbage in, garbage out. So the quality of data is very important, and whether to ascertain and find out whether there is some sort of biases that exist in this data. So eliminating this bias is a big problem in trying to sort of make semblance. And there's something called interpretability, and there is something called black box sort of a phenomena that happens in AI, where so you put there's a sort of lot of data that is fed, and AI gives you certain solutions, and humanly, it is very difficult for us to understand how that analysis was made or how that outcome sort of a prediction was made. So even humanly, so some of the data that gets generated out of all the input data, one cannot make semblance as to why such a decision was made. So this is called black box problems. So this sort of yeah, we tend to have a pessimistic approach and fail to have a trust in these sort of mechanisms. And there's something called workflow fit, because there are a lot of alerts that AI generates because of integration of so many variables. There can be a lot of alerts that come out, and not necessarily they may be contextually relevant. So these alarms may not be very relevant from the clinical standpoint, and this can lead to alarm fatigue also. So these are some of the challenges that one could face. And there are ethical issues which I have spoken about. So there is the problem with the privacy. So the data privacy is a big problem, and consent from the patients, that you are okay to feed all this patient's data into AI models is something. Consent and accountability. So these are some of the legal and ethical challenges when we are applying AI into our patient care. And with regards to enablers, so AI has to be human centric, and it should be clinically interpretable. So whatever solutions AI is giving should be clinically interpretable, and it should be workflow compatible. And AI's utility should be to assist, and it should not be with an intent to automate your work. So it should be able to synergize your workflow. And it should AI, even with the advances in AI, it should be the clinician first. So, which is called as we have to preserve the primacy. Primacy means it has to be clinician first, patient centric, which are enabled and assisted by AI and not look at it as an automated way of managing the patients. So when you look into the Indian context and future vision, so India, we understand, is a very heterogeneous country. So I cannot use the word India is resource limited. There is sort of a disparity and there is a heterogeneity with the socio-economic standing and there is a patient overload. So we have unique advantage with this patient overload because we become data rich and we become data diverse because there is a saying, the best thing about India is diversity and the worst thing of India is diversity. So these become very pertinent in AI because of the large data, we become data rich and diversity also adds sort of a compartmentalization or making sense of the data. And digital skills could be created because of this rich data. So the whole future in India is EICU networks, which I keep mentioning in every talk these days, along with telemedicine, along with national digital health mission. This is the way forward, friends. In every talk I'm telling, the future of healthcare in India or the hospital groups in India is only success would be manifested if these are incorporated for the future. If any hospital which falls short of incorporating tele ICU, and only if you have tele integrated network, then AI algorithms could be manifested. If you do not have a integrated tele ICU network, then the AI algorithms cannot be incorporated. And Indian government is taking sort of a phenomenal steps in having this national digital health mission where there's a health card issued to the patient. What is this health card? Health card is basically assimilating the health data of each individual so that algorithms could be created. So I think every hospital chain should invest into telemedicine or a tele ICU and integrated network. These are the two buzzwords. We have to integrate to make semblance of AI algorithms, which helps in sepsis surveillance as well. And it has to be a collaborative project where large set of data, the large language models are integrated with metagenomics, and there should be a real-time data flow. So there is two types of data flow, synchronous and asynchronous. Asynchronous is the data that you fed. Synchronous is whatever monitor you are visualizing in ICU, they are constantly fed into the AI algorithms, and AI is sort of making some sense of all this data and predictive analytics are made. So this integration is essential for precision approach towards sepsis treatment and in our ability to phenotype the sepsis in India and trying to sort of stratify sepsis based on the pathogens in India and and this can calibrate to the healthcare realities that prevail in various parts of India. So this is where collaboration has to happen in the futuristic standpoint. And AI helps in triaging. So TMM, remember TMM. So AI even helps in triaging, monitoring, and mentoring. So these are the three elements that you should look at AI as. So conclusion, friends. So look at AI as a tool which is not to replace intensivist, but to help synergize the care with intensivist. So use AI as a tool to synergize our ability to provide good care to the patients. And the AI helps us to change our optics from reactive to proactive sort of a care with predictive analytics, protocolized approach to patient management, and personalized to the different host milieus that we deal with. So different, each individual is different. So personalizing the care of the personalized sepsis care based on the phenotype of the patient is where we are headed. And AI should respond to the dynamic changes that happen in a patient with sepsis. So these are the four salient aspects that AI can help. Being predictive, help us to deliver protocolized management, personalize the care to the different types of phenotypes of the host, and be dynamic. So because sepsis is not a static condition, and calibrating to the dynamic changes that happen to the sepsis is where AI can be assessed. And AI should be looked at amplifying the clinical intuition and computational foresight. So one has to look at AI as an amplifier of clinical intuition and computational foresight. And AI is not about man versus machine. It is man with the machine to provide timely care, to save more lives, and to ascertain the survival chain. So timely survival chain is something that can be better. So this is where one has to look at AI. So that's about it, friends. So it's a beautiful quote in sepsis. We know every minute counts, but with AI, every data point can too. So in AI, it becomes that. So every data that is fed acts as a tool to save a life, as every minute helps you to save life in sepsis. So that's a beautiful quote. So thank you, friends. Request you all to submit your valuable work to Journal of Acute Care. Of course, you can visit my website to read to this lecture. Thank you. Thank you, one and all.